So welcome everyone to the eMedica MRCGP AKT Essentials webinar. We're going to cover keys to success in the AKT. So a brief introduction for anyone that hasn't met me. So my name is Muhibur Rahman. I'm a portfolio GP, which means I'm a GP with multiple roles, based here in Birmingham and Solihull. I passed my own MRCGP with merit back in 2007, and I got FRCGP in 2019 for my work in medical education. I've been teaching and writing on MRCGP and GP careers for over 17 years now. And I'm one of the authors of the National Prescribing Safety Assessment that some of you will have sat when you were starting foundation program. And our team at eMedica now have trained over 60,000 delegates since 2005 when we started offering courses and resources. And, you know, as I mentioned, I'm a portfolio GP, so it means I've got different jobs, different roles. So I'm a partner in my own practice. I'm one of the GPs at a secure unit for women with significant mental health. I cover community detox unit. And then I have non-clinical roles. So as well as teaching for eMedica, I've taught courses with and in conjunction with or on behalf of Health Education East of England, KSS, some of the training schemes in London and West Midlands. We've also run national revision courses for AKT through the Rcgp website with Rcgp Beds and Hearts faculty. So let's make a start on the learning objectives that I hope to achieve over the next hour. By the end of this hour, you know exactly what to expect in the AKT exam, the exam format, different types of questions, some of the new formats you might not be expecting, and what they're actually testing. You'll know how to prepare effectively. What are the common pitfalls that can lead doctors to fail, and how can you avoid those? And right at the end, we're going to cover what are the habits of those that don't just pass, but smash the exam, the high scorers, the keys to success. We'll also touch on how we can support you if you want additional support for AKT, the different resources and courses that eMedica offer. And hopefully by the end of today, you will have kick-started your AKT preparation. Okay, so let's start with an overview of the exam. So the first thing is you can only sit the AKT once you're in ST2 of training or later. So you can sit in ST2 or ST3, cannot sit in ST1, cannot sit it before you start training. And it's available 3 times a year. So it's the last Wednesday usually of October, of January, and of April. The default maximum is 4 attempts. You can see here I've put brackets +1. In exceptional circumstances, someone that used 4 attempts at AKT and hadn't passed, if they had passed the RCA or equivalent, and their trainer was happy with their workplace-based assessment, and they got support from both their program director, educational supervisor, and then got approval from the RCGP, in exceptional circumstances, some doctors are granted a 5th attempt, but that's the exception, not the norm. So the whole thing's done on computer, and one of the big challenges is time. So you're going to do 200 questions, you'll have 190 minutes for standard timing. And the way that it's made up, those 200 questions, 160 questions, so 80% of the questions are clinical medicine relevant to UK GP. 10%, so just 20 questions, are evidence interpretation, statistics, evidence-based medicine, graphs, charts, data interpretation. And 10% is the organizational domain, sometimes described as the admin part of the exam. So this includes things like practice management, types of GP contract, clinical governance, information governance, some of the medical legal issues, ethical issues, things like that. The main format you're all familiar with, because the main format in the MSRA, which is set to get into GP training. So the main format, about 80 to 85% of the questions in the exam are extended matching questions and single best answers. They're the main formats. You're all familiar with this. But there's lots of other formats, some which you'll be a bit less familiar with, and some that are newer, have only been used in the AKT in recent years. So you might get multiple best answers where there's more than one correct answer, and you've got to get it fully right to get the 1 mark. Some questions will have an algorithm, and you might need to drag certain labels into the right place to show that you know that guideline. There may be questions with a picture attached to it. Skin lesion, an eye, fundoscopy, an inner ear, an audiogram, a urine dipstick, a blood report, an ECG. There may be 1 or 2 questions testing knowledge of seminal trials, big trials that have had an impact on GP. And the newer formats are short answer questions where there's no options to guess from. There's a question and a blank space, and you use your keyboard to type the answer, and it's a short answer. It's not an essay. It's 1, 2, 3 words maximum. Okay. And then video questions is probably the newest format. So there'll be a video clip, no more than 30 seconds, and then again, a case or question attached to it. Okay, so I'm going to give you some examples of some of these other formats, newer formats and alternative formats, because they're ones you're less familiar with. You're all familiar with extended matching questions and single best answers. So as I said, I want to make this session interactive. So we're going to cover 12 questions across clinical stats admin throughout the whole hour. So what I'd like you to do, write down at home on a piece of paper or on your phone, numbers 1 to 12, and just note down the answers as we go, because when I then go through the answer and explanations, you can keep a track of if you got it right. And the way I'll do it is I'll show you a question, give you about 55 seconds to think about it. I'll turn my video off so I don't distract you. First question's coming now, 55 seconds, okay? Here we go. Now, you'll notice this is what we call a multiple best answer. You see, it says which two of the following. So to get the 1 mark, there's only 1 mark for each question in AKT. But to get that 1 mark, you have to get them both right. Let's say someone got 1 right and 1 wrong. You won't get half a mark. You get nothing, unfortunately. The marking is really strict in AKT. So I'll stop you there. And you can see that, there's lots of options here. So sometimes in AKT questions, there can be up to like 12 options. So there's a lot to read just to even look at the answer options, okay? So the popular answer options, most of you have picked A, and then the other two that are really popular are G and H, okay? So the correct answer is B and H. So you'd need to have both B and H to get the 1 mark. So very few of you got both of those. There's quite a lot of you that got one of them because H was quite popular. But very few people picked B as the second one. Most of you picked A instead. And so you wouldn't get a mark for that, okay? Because if you get 1 right and 1 wrong, you get nothing, okay? Let's look at why. So you need both B and H to get the 1 mark. If you got 1 right, 1 wrong, as I said, you would get nothing in the AKT, unfortunately. It's the way it's marked. So this comes from the NICE hypertension guidelines. And actually, in the last examiner's report, the examiners highlighted hypertension as a topic that we'd expect most GPs to deal with most days in real life practice. It's a good example of a really common topic, but it's also an important topic because it's such a big risk factor for cardiovascular disease, right? So once you've confirmed someone as having high blood pressure, the main investigations are really looking at establishing a baseline and looking at cardiovascular risk, things that we can modify. So you want to do a urine dipstick for hematuria, but you need to send the urine to the lab for albumin creatinine ratio and proteinuria. Urine dipsticks are not accurate for proteinuria in this context. Then you take bloods to check renal function, EGFR, HbA1c in case they might have diabetes and we don't know about it yet, lipids for cardiovascular risk, fundoscopy to check if they've already got target organ damage. Could they already have established hypertensive retinopathy? And then a 12-lead ECG as a baseline. What kinds of things might you see if someone had had hypertension for a long time, undiagnosed, because often it's asymptomatic, right? What might that lead to that we might pick up on a 12-lead ECG? Let me know in the chat. Yeah, absolutely. Well done. The main thing is left ventricular hypertrophy is one of the things that if someone's had a history of hypertension undiagnosed for a long time, you might see changes of left ventricular hypertrophy on a 12-lead. And if you saw that and it was significant, then you can see you might send them actually for further imaging. So just want to highlight 2 really important things about doing well in AKT. One is that the level of knowledge, the detail and the level of knowledge being tested is that of a qualified GP. It's high level, but it's things that are happening in general practice. The second is that as well as having knowledge, you've got to have good exam techniques. Let me show you. To go back to the question, the most popular answer, which was wrong, was A. Urine dipstick for proteinuria is incorrect. A lot of people just saw urine proteinuria and they thought, oh yes, because in hospital, you will have regularly seen urine being tested for albumin creatinine ratio and for proteinuria in the lab, right? But you see, it's not a dipstick. The urine dipstick's okay for hematuria, but you need lab urine for proteinuria and albumin creatinine ratio rather than just a dipstick. So do you see that if someone just saw urine in a rush, just read this bit, didn't read that it's a dipstick rather than sending it to the lab, that's a good example of exam technique. You could have the knowledge, but still lose marks because you misread or misunderstood one key word or one key feature. Similarly, some of you picked G, retinal imaging for hypertensive retinopathy. We don't send everyone with newly diagnosed hypertension for imaging. The system couldn't cope with that. But what can we do in practice? Really easy. The patient's in front of us. Take your otoscope, have a look in the back of the eye. If you saw changes there that you're worried about, you then might send that subset for imaging. Okay. And then option I, very few people picked up, a few people did pick it. ABPI measurement, that will be for suspected peripheral arterial disease, not for someone with hypertension alone. Okay. So let's move on to question number 2. Now, this is an example of a video question. There's no audio on purpose. So it's a good example of a video question. Can you see there was a short clip, not more than 30 seconds. They usually don't have audio. And you're going to take information from that clip alongside information from here, the case, and then you still got time to then think about your answer. Okay, so I'll stop it there. So the most popular answer was A, prednisolone for 10 days. The correct answer, though, is E, no medical treatment required. Okay, and less than a third of you got this one right. It's a hard question, but again, 2 things I want to highlight from it. One is the knowledge base and the exam technique that we already talked about. But the second is something the examiners have highlighted, that a lot of times in general practice, we don't need to give anyone a treatment. We don't need to send them for tests. We don't need to refer them. We just need to know what is the natural course of this disease. There's a lot of things that are self-limiting that will resolve themselves. And all we need to do is keep an eye on it. And we don't need to actually give any medical treatment. Okay. And there are a lot of cases where doctors, that's what they think, but then they think, that seems too straightforward. And be honest, is there anyone that actually was drawn to thinking, okay, this looks like Bell's palsy, didn't have any weakness or slurred speech, you can see from the video, it's one side of the face is, paralyzed, very classical appearance. She's young, it's not bilateral, there's no big risk factors. You see, but then you thought that's too easy. So you actually thought E, but then you changed your mind and changed it to one of the others, not because that's what you thought fit, but you thought they're making it too easy for me. They're trying to get me. Is anyone that thought that? Usually there's at least a few people. Okay. Yeah. Okay. And this again is a really important part of technique, that nobody's trying to get you. We all want you to pass. All right. We're short 10,000 GPs in the UK. Right. We want you to pass, get your CCT. The only person out to get you is in your chair. And sometimes as doctors, we sabotage ourselves. If you're not really confident in your knowledge base and you think something's too easy and you think, oh, someone's trying to get you, you'll change your answer. Whereas if you're confident, I know that as this lady has had symptoms for 10 days, I know that the cutoff to offer treatment like prednisolone is 72 hours. Therefore, there's no benefit in offering medical treatment. She hasn't got any big risk factors, so she doesn't need a referral to ENT. Therefore, I don't need to do anything. And if you're confident that this is an easy question for me because I've learned it, and you own your knowledge and you're confident in your approach, then you're going to stick with your first instinct and your gut, and you're not going to change. Okay. Someone said that usually in their practice, they give prednisolone. That's a really good example of, there might be lots of things that happen locally or that you do in hospital, but that isn't the right thing in an exam where they're going to base it on nationally published guidance. There's a nice guideline on this. Okay. And what does that say? Well, it says that if you catch it within the first 72 hours, there is a good evidence base for prednisolone, high dose for 10 days. Okay. There is no evidence for acyclovir on its own for the treatment of Bell's. there is limited evidence of acyclovir and prednisolone as a combination, again, if caught within 72 hours of symptoms starting, but that's only recommended under specialist supervision. It wouldn't be something we'd be doing in GP. Okay, and that's what the answer is going to be based on, which might be different to what you do locally. They can't base the answer for a national exam for the whole of the UK on things that are happening in some areas and aren't recommended or aren't available nationally. Okay, so correct answer is E. Okay, so two things from that. So Bell's palsy, it's an acute, one-sided idiopathic facial nerve paralysis. Most patients will make a full recovery. However, if they present within first 72 hours of symptoms, very good evidence base that giving high-dose prednisolone can improve recovery. And what would be the indications to refer to ENT? Because that was one of the options. High risk, so bilateral Bell's, not common, but can happen. Recurrent Bell's, if we're not clear what the diagnosis is, or if they've had symptoms for a full month and made no improvement at all. We don't expect a full recovery in a month. That can take up to 9 months. But within a month, you'd expect some recovery. So if any of, and none of those, this patient had only had 10 days, so we haven't got this far yet. Okay. Okay, now this is an example of a free text question, but it's testing knowledge of a seminal trial. You see, there are no options here. So once you're ready, type your answers. Okay, great. So let me show you the only thing that would get you the mark. So the name of this study is a very famous study. It's called the Million Women Study. They recruited actually over 1 million women. It's one of the largest cohorts and data sets ever assembled. Initially, it was just about looking at the risks and benefits of hormone therapy, particularly for breast cancer. So nobody had breast cancer at the beginning of the study. Half were on HRT, half were not on HRT, and it's still ongoing. They're following it up to this day. I remember this study because 1996 is when I started medical school. Okay, so if you mistyped it, so you typed million wrong. You had one L instead of two. You put woman instead of women, or you didn't put the word study and just put million women. You'd still get the mark. The common misspelled variations, as long as you know the study, you get the mark. If you put the type of study, so this was a prospective cohort study, there are no marks for that. Why? The question asked the name of the study, not what type of study was this. What type of study is this describing? It's describing a prospective cohort study. See, there are no marks for that because that's not what the question was asking. Again, reading the question carefully is part of exam technique. So this study is called the Million Women Study. It's a landmark study. It's a seminal trial. So, it's a good example of something that they could actually include in the exam. Okay. Right. Let's move on to number 4. Tip about any picture question. Make sure you look at both the picture and the scenario. Okay, great. Now, so before we look at the answer, what do you think the diagnosis is? Because that could be a question in itself. They could give you this same image, same background case history, and the question could be, what's the single most likely diagnosis? And there could be a list of options. Okay, so what do you think the diagnosis is? So this is an example of a 2-step question. First step is working out the diagnosis. The second step, in some cases, based on the diagnosis, might differ. In some cases, it might still be the same. Okay, but if you had a question on diagnosis, you might get it wrong. All right, so people have said that they think it's either a sty or chalazion. So let me ask you a question before we go to the answer. Are they the same thing? Is a sty and a chalazion, are they the same? No, they're not. Okay, good. So what this actually is a Meibomian cyst or chalazion. That's not the same as a sty. So how could we separate it in terms of the diagnosis? Well, they both actually look very similar. Like a sty could start like this. Okay, it could look like this in the early phase. I know what this actually was because I know where the image is from. All right. But the key thing is in the history. This is why if you just look at the picture, you just look at the scenario, you'll often get these wrong. Okay, because they could look similar. The key is this: there's no pain or effect on the vision, and it's non-tender, the lump. Okay, a sty is usually exquisitely tender, whereas a chalazion or Meibomian cyst is usually non-tender. A sty would be very tender when you examine it. Okay, so that's one of the ways you can separate it. Okay, but in terms of management, actually, if there's no sort of other worrying features, both of them you could manage with self-care, warm compress and massage. All right, but in this case, definitely that would be the right management because of Meibomian cyst. All right. So what causes this? Basically, blockage and inflammation of the Meibomian gland. In a lot of cases, it'll get better on its own. Things like a warm compress, massaging can help to speed it up a little bit, but usually they settle in a couple of weeks. Okay. You'd only give antibiotics if they had a conjunctivitis at the same time. If we go back to the image, you can see this is all healthy. There's not like redness there. There's not. It doesn't look infected. Okay. There's not like a pus here. It's not described as being sticky. So there's no indication for that. And then when would you think about referring? If it had no improvement after about 4 weeks on conservative treatment, then you might. They've only had this for 5 days. So there's no indication for, even a routine referral. Okay, question 5. So in the exam, you'd be dragging these labels to the right place. Okay, so just imagine where you'd like to drag, which one fits stroke risk, which one fits bleeding risk. Okay, what you would be doing is you'd be dragging Chad's Vasc for stroke risk and be dragging Orbit for bleeding risk. Again, you need both right to get the 1 mark. So the common mistake is a lot of people would get Chad's Vasc right, but instead of Orbit for bleeding risk, they'd put has bled, which was the old scoring system for bleeding risk. You'd get no marks for that. Again, no half marks in AKT. Okay, so Chad's Vasc, you get 1 for any of these. The reason there's an A2 and an S2 is if the age is 75 plus, you get 2 marks. And S2 is if you've had a stroke, TIA, thromboembolism, you get 2 marks. All of the others give you a mark. Score 1+ for men, 2+ for women. Consider anticoagulation, okay, to try to reduce that stroke risk. And then Orbit is the new recommended bleeding risk score by NICE. They recognize that in some cases, people will still use has bled as a rough and ready thing, but what's recommended is to use Orbit because it's that much more accurate. One of the reasons it's more accurate is that, it's not just based on history, it's based on taking some bloods and actually getting objective measures of increased risk. Okay. Now, the clinical questions, so I've shown you some of the different formats that you might be less familiar with. So I'm going to talk to you a little bit more about the exam, and then we're going to do like a mini mock, just a few questions, okay? Just to get used to doing one question after the other. So the clinical questions, which is what we've touched on so far, we'll do some stats and admin later. They will relate to, as you've already seen, some will be about disease factors. So, typical features, symptoms, risk factors. Some would be about making a diagnosis. So, patient presents with XYZ on examination, there's ABC. Which of these is the most likely diagnosis? And we sort of talked about that when we talked about the Meibomian cyst. Some would be about investigations. Again, we looked at, you've diagnosed someone with hypertension. Which of these are the right tests to do in this situation? Some will be about management plans. And that could include knowing who to refer urgently, who to admit, who to refer non-urgently, who to do nothing, who to manage in primary care. Some questions will be more specifically about prescribing, and that can be quite detailed, including knowing common doses for important and common drugs. And then there'll also be questions about emergency care. So don't forget that the GP curriculum isn't just what we do in hours, it also includes everything out of hours. Okay, so emergencies that you might see on home visit or in out of hours, or even in clinic, anything from an anaphylaxis to an acute severe asthma to a suspected meningitis and everything in between. And the questions will include those things that are about low impact common conditions, acne, eczema, but also high impact rarer conditions. You probably see someone with sore throat that could be a virus a few times a week this time of year, in the winter, a few times a day. You might see someone with a sore throat that could be a head and neck cancer once or twice a year. Much rarer, but higher impact. So you still need to recognize it and know how to deal with it. Common reasons for consulting. There'll always be questions on things like sick notes, because that's a common reason for someone to consult. There's never been an AKT without questions on contraception. Someone wants contraception to not get pregnant. They're not sick, are they? It's a common reason to see your GP. And then areas identified as problems in the past. So if you look at the marks by different subject areas from exam statistics, and then the examiners publish a feedback report after each exam. And if you read that carefully, you can pick out some of the topics that are likely to be retested in the next few sittings. And if we look at the pass mark and pass rate, the AKT is what we call a standard set exam. So they set the pass mark before you sit the exam. It doesn't matter how you do compared to others. It matters how you do compared to the set pass mark. So all of you could pass if you're above the pass mark. All of you could fail if you're below the pass mark. Just because you did better than your friends, if your friend was below the cutoff and so were you both fell. How you do compared to others makes no difference. The pass mark is set before anyone has sat the exam. Now, they changed officially the pass standard after AKT 7. We've had 45 AKTs so far, okay? And what happened after that is the pass rate dropped. So the pass mark, the lowest it's been is 66, the highest is 72, long-term mean 68 and a bit, although the last few exams it's been over 71%. The pass rate, long-term mean, since the new standard, 71%. I've tracked every exam stats since the very first one, and I've got a huge spreadsheet. And just before I came on today, I updated it. And what's interesting is if we look at the last 3 years, the last 9 exams, the pass rate is 67% across those 9 exams, i.e. about 1 in 3 are failing. It's a lot lower than it was the first few years of the exam. In fact, the last exam was the lowest pass rate ever. Only 60% of people passed the exam, the last exam, okay? And if we look at how people do by subject area, people do worst in the admin section, okay? They do better in medicine and stats, but they do worst in admin. So let's do a little mini mock. Chance to, again, see some more AKT questions, but also I want to introduce some stats and admin because we've only seen clinical so far. You can use a calculator for any of these questions if you need to, because there is a calculator on the screen when you sit the exam. And what will happen is this time, I'm just going to show you 7 questions because we did 5 already. We're doing 12 in total. And after 55 seconds, the slides will move forward automatically, okay? And then just note down your answers at home. We'll go through the answers afterwards, okay? Here we go. Well done, everyone. So let's go through the answers. Okay, so question number 6. It's a good example of one of the newer style data interpretation questions. This is using real life data. I pulled this data from Public Health England website, and they're increasingly using real life data like this in the exam. Okay, great. So the correct answer is D, Lambeth. And actually, well done. Most of you got that right. But a lot of people that didn't get it right picked A, Croydon. Okay, so let's look at why you might have got that. So the question's asking about the region which has worst infant mortality rate. Okay, so if you look here, this is the count. This is how many infants died. Okay, whereas this crude rate per thousand, the death rate is how many died per thousand. These different areas will have different levels of population. Some will be bigger areas than others. So the figure, if we asked to look at the infant mortality rate, is this one, the value. This is the deaths per thousand. Okay, so the worst infant mortality is the highest number. So all you need to do is look down here and look at the highest number. The highest number is 4.7 deaths per thousand, which is Lambeth. You see, so why might someone have picked Croydon? Because Croydon had the highest number. The count is the number of deaths. But Croydon is a much bigger area. You see, so although they had 72 deaths, deaths per thousand is 4.4. That's lower than Lambeth's rate of 4.7 per thousand. Okay, and then a few people picked down here Barnet. Why might they have picked Barnet? What you've done is you've actually picked the area that had the best infant mortality. Because can you see, we don't want any babies to die. But unfortunately, some will for various causes. So can you see, the lower the rate of infant mortality, the better. The question was asking for the worst rate, not the best rate. The best rate is in Barnet. They only have 2.7 deaths per thousand. That's better than any of the other areas. Do you see? Okay. So look, this is the actual number, because you might get a different question that said, which of these areas had the highest number of deaths in the period shown in this table? In which case that would be Croydon, okay, had the highest number of deaths. But the question was about mortality rate, that's deaths per thousand, okay? And then in another question, they might ask you to identify the 95% confidence interval for a specific area. So they might say, what's the 95% confidence interval for the area with the best infant mortality rate? So first, Barnet has the best rate, and then the 95% confidence interval is this, and written down is here, 1.9 to 3.6 deaths per thousand, okay? Question number 7. So this is something that was again highlighted by examiners recently about certain conditions where we have to think about monitoring, but also certain medications where you might be thinking about drug monitoring. So there's chronic disease monitoring and there's drug monitoring. They're both important topics that have been highlighted. So two most popular answers are A and B, very closely followed by D. The correct answer is B. So this lady has developed gestational diabetes, the first pregnancy, so she can't have had a previous episode of gestational diabetes. And then we've tested her postnatally and confirmed she doesn't have diabetes. So, but having had gestational diabetes is a risk factor for having diabetes later on. So that's why we want to screen her annually using HbA1c. So again, sometimes it's small things that make the difference. So some people picked C. Annual screening isn't via OGTT. Now you could be confused because during pregnancy for gestational diabetes, OGTT is the test of choice because HbA1c is not accurate. But this isn't when she's pregnant. This is just annual screening going forward. So OGTT would be over the top. Okay. And then D and E, it's because of this bit that she doesn't need regular screening after this. They'll need regular screening ongoing every year. Okay. So having gestational diabetes increases your risk of diabetes going forward from that point. The postnatal check, if it's done, usually it's done somewhere between 6 and 13 weeks. If it's done sort of before 13 weeks, we'll use fasting glucose to see if they're actually diabetic or not. After that, we can either use fasting glucose or HbA1c. We wouldn't use OGTT routinely for diabetes tests. And then ongoing annual screening is HbA1c. That's what the guideline recommends. Okay, now this is an example of a free text question, and I'm going to highlight something important because remember I mentioned spelling mistakes when we're talking about the Million Women study will still get you the mark. When it's to do with drugs and when it's to do with dosages, having one letter out, you will not get the mark. Spelling mistakes will not be rewarded. That's because that could lead to a medication error. You know, writing MCG instead of MG is totally the wrong dose. So, small things like that can make a difference. Okay, so the correct answer is 40 milligrams. Okay, And a lot of you have got that, so well done. But why might some of you have got 20? This is, again, exam technique. So the first thing is, you can see this is someone, and every single AKT has to have at least one drug calculation. Usually there'll be two. One to do with cancer pain, one to do with pediatric dosage calculations, okay? So a lot of people look at things like the diclofenac and the paracetamol. While they're relevant as part of this patient's overall analgesia, the question is specifically about the dose of morphine that's equivalent to this patient's current 24-hour dose of tramadol. So the first step is to see they're on tramadol 200 modified release twice daily. So how much tramadol are they on? 400. The next bit is the knowledge, knowing that oral morphine is 10 times stronger than tramadol. And so 400 milligrams of tramadol is equivalent to 40 milligrams of morphine, okay? Now, if you put 40 milligrams, 40 mg, you'd get the mark. If you put 40 and you typed out milligrams in words, you'd get the mark. If you just put 40, you would not get the mark for this question. Because can you see, it might be 40 grams, it might be 40 micrograms. Without the unit, that dose is incomplete and unsafe. So you would not get the mark for just writing 40. And a lot of you have done that. Now, it might be that in the exam, you'd actually write mg, but it might be that it's good that you've made that mistake here with me, so you don't do it in the exam. Because if you type 40, you would not get the mark. You need to have 40 milligrams, okay? Those that put 20, you might have missed that it's twice daily and thought, oh, they're on 200. Again, this happens when you're in a rush. 200, so that's 20. That's the right conversion, but you haven't accounted that they're taking 200 twice daily, so that's 400 in total, because it asks for the 24-hour dose, okay? In terms of opioid conversion, so oral morphine is the universal opioid. 10 milligrams of oral morphine is equivalent to 5 milligrams of morphine given by injection. It's equivalent to about 6.6 milligrams of oxycodone. So oxycodone is about 1.5 times stronger. Equivalent to about 3 milligrams of diamorphine given by injection. And then tramadol and codeine are both 10 times weaker than oral morphine. So 100 milligrams of tramadol is the same as 10 of oral morphine. 100 milligrams of codeine, same as 10 of oral morphine. Okay. Blood pressure. We looked at how to deal with it once we've diagnosed it. How do we assess it? So let's look at this one. So key thing, this is all 3 readings were taken in the same visit in clinic and they're on any medication already. All right. So the correct answer is E. They don't need any treatment because they're normotensive. We repeat the blood pressure within 5 years. Less than a fifth of you got that right. And the most popular answer was actually arrange ambulatory blood pressure measurement. All right. And so this is again where it goes beyond just reading at a rapid level and maybe having heard of a guideline and understanding it and actually using it in real life. It's a good example where if spending some time in general practice and actually seeing these things day to day makes it easier. So what does NICE recommend in terms of assessing hypertension? That if the first reading is above 140 over 90, i.e. it's at a level where we'd be worried about hypertension, then you do at least one more. But if the second one is significantly different to the first one, as is the case here, then you must do a third one. Once you've done a third one, ignore number 1, and out of 2 and 3, you take the lowest, and that's the one you document. So the blood pressure I document for this patient is number 3, 118 over 70. That's absolutely normal, so there's no risk here. So repeat it within 5 years of what the guideline recommends. That's why it's E. As you can see, if you didn't know the guideline, and you just guessed, and you thought, oh, you know what, even if you knew that you're going to take the lowest of it, so in the old guideline, we used to take the average, but in the new guideline, you take the lowest. If you were guessing rather than knowing what the guideline says, you'd think, oh, maybe repeat it in 6 months or repeat it in some time, do you see? And very few people selected, start treatment. That would be for someone, where the readings are confirmed to be hypertensive after ambulatory blood pressure monitoring or home blood pressure monitoring, or if it was really high in clinic, then you might, if they had evidence of target organ damage. So you take up to 3 readings. If the first one's normotensive, you can just document it. But if the first one's high, you must take at least 1 more. If the second one's significantly different, take a third one, and then document the lowest of number 2 and 3. If that's less than 140 over 90, they're normotensive. Repeat it within 5 years. If it's 140 over 90 or more, offer either ambulatory blood pressure monitoring or home blood pressure monitoring, so you get an average reading to make an actual diagnosis. If it's 180 over 120 or more, then depending on whether they've got some evidence of target organ damage or if they've got other worrying features that might make you think about things like pheochromocytoma or malignant hypertension, you're either going to start treatment while you wait for an average reading, or you might even admit or refer to hospital. So you can see, first one was high, So do at least a second one. Quite different between 1 and 2. So ignore 1 now and do a third one. The lowest one of the 3 is the one we document. The lowest one out of number 2 and 3. Right. Question number 10. Again, you see when there's a lot of options, often takes a while just to read it. And this is a 2-step question. What do you think the diagnosis is? So look at this description. Look at the image. Put those together. And what do you think the diagnosis is first? Because that could be a question, right? So someone suggested that they thought it might be vitiligo. Someone else suggested that it might be pityriasis versicolor. Someone else just thought it could be chronic plaque psoriasis. Okay. Okay. So what this actually is pityriasis versicolor. In vitiligo, you also get depigmentation rather than just areas of hyperpigmentation. What you wouldn't get is areas of other color. Pityriasis versicolor literally translates that versicolor to multicolor. So do you see there is areas of hypopigmentation, but you also get these areas of pink quite typically, and that's what versicolor looks like. So that's first line treatment for that would be ketoconazole. So use ketoconazole shampoo as like a wash. Okay. Sometimes you can also use like an ointment or a cream, but ketoconazole is the key. Okay. So H is the right answer. Number 11. Again, something really important. Any picture question, look at both the picture and the scenario. If you just look at one or the other, you could easily miss things. Okay, great. So what do you think this is? So this fits with tinea, right? Just looks like a quite typical dermatophyte infection. So you've got the raised bit, you've got the flat center, you've got these sort of bits that looked like little dimples, and then the fact that it's really itchy, and look where it is. Okay. You know, they've got a risk factor as well, having diabetes. And so this, terbinafine, topical terbinafine, if it's only a few patches, would be fine. So G is the right answer. And last one, this is from the admin domain, okay? Looking at GP contracts. So nationally negotiated contract, the most common contract for NHS GP practice in the UK. The correct answer is A, General Medical Services. GMS is the most common NHS GP contract, and it's a nationally negotiated contract, whereas PMS, Personal Medical Services, is a locally negotiated contract. General Practice Medical Services, a lot of people that have no idea about these would guess that because it sounds like it would be the right name. That's not the name of any NHS contract. That doesn't actually exist. Okay. So GMS stands for General Medical Services, a nationally agreed contract, nationally agreed terms, conditions, and pricing. The most common NHS GP contract throughout the whole of the UK. Within the contract, there's 3 levels of service. Essential services, all GMS practices must provide. You cannot opt out of any essential services. Additional services, usually you provide these for your patients. You could choose to opt out, but for each one you opt out, you lose some of your funding. And then enhanced services, you might be able to opt in for extra funding. Okay. So add up your score. So you get a total out of 12. We did 5 questions before the mock, 7 questions in the mock. So 12 in total. I'll give you a second to do that. And then you don't need to tell me your score, but to give you an idea, if this was the real exam, bear in mind the real exam is 200 questions. We've only done a selection of 12, okay? But 10 or over is excellent. That would be a clear pass. In the old days, you might even get a merit with that, okay? You can't get merit now, you either pass or fail. 9 or more would be a pass in any sitting of the AKT historically, because it's above 72%. 8 is borderline. It would just be a pass in some sittings, but for example, in some sittings when the pass mark was set higher, like last time, it would just be a fail, okay? And 7 or less, don't worry. You're not sitting the exam next week, are you? If you're sitting the exam next week and you're at 7 or less, okay, you're not ready and maybe you don't want to sit it. But you're not sitting the exam. Even those of you sitting in October, you've still got months to go. And a lot of you haven't even started your prep. A lot of you have only just started and not started, the serious part of your prep. You're just doing a little bit of reading and maybe touched a few questions, all right? But one of the things I want to highlight is this is a hard exam. You see, look at the stats from recent exams. It's a hard exam and it's got harder in the last few years because the curriculum's bigger. So let's look at then common reasons for failure, and then we'll finish at the end with how to sort of counteract that, the habits of the high performers, the keys to success. Okay, so common reasons for failure: rushing to sit the exam or to resit. So I get some registrars that the minute they hit ST2, they feel pressured that they have to sit it because some of their friends are sitting it. And it might be that their friend already had some exposure to GP in F2, and maybe their friend had a good rotation to study during that period, and the friend managed to get through it. And the friend also had already done ST1, a GP rotation. And it might be for this doctor, they're in a really busy rotation and they've got very little or no private GP exposure, and it might not be the right time for you. Don't rush to sit it the first attempt that is possible for you to sit it. Sit it when you're ready and you're going to have time to study and you're going to have time to prepare effectively. And it's much better to do that and then pass first time. And if you don't pass first time, don't rush to immediately book the next available date and not analyze why you failed and have time to remedy that and then end up failing again. And then that can start affecting your mindset and knock your confidence. Okay, be better to delay and sit it when you're properly prepared, and then you pass your visa. Okay, not allowing enough time. So as a result, not covering the whole curriculum, just covering things that they prefer to read or things that they picked up from a question bank without actually knowing. Sometimes people don't even know what's in the curriculum, so they don't know what they've missed. Poor clinical topic coverage. You need to know it in depth as well as breadth. You need to know the details of it. Not up to date with recent guidance. So sometimes people will only rely on things like textbook or some of the notes from previous exams, but the guidelines might have changed since then. Focusing on just one source for learning, like picking one question bank and just doing that same one several times. So you learn the questions off by heart, but you're not going to get any of those questions. You're going to get other questions on those topics. You haven't actually learned the subject and understood it well. So then you end up getting a great score the fourth attempt at the same question bank. You're getting 95% and then fail the exam by a few percent. Poor confidence with stats and admin. While these are only 10% each, if you can get good marks in stats and admin, 80% plus, then you can get away with 70% in clinical. Whereas if you don't get a really good score in stats and admin, you're going to need 75 to 80% in clinical to have any chance of passing. That's really tough. Okay. Poor exam technique. As we highlighted today, sometimes you can have the knowledge and still lose marks if you actually misread the question, misunderstand what the examiner is asking, things like that. So I'll link this into the keys to success and the habits of the high performers at the end. But I want to touch on how to prepare. So first thing is try to make the bulk of your learning active. You can see if you're just reading, for example, that's passive. Now, that's got a place in it. I'm not saying don't do any reading. You need to do some reading. But for example, if you read, you can make your reading active if you then summarize the key learning points in your own words. You make notes after you've read. Okay. And then by doing questions and then actively thinking like we've done, you see, that help make sure you've actually understood and can apply it. Allow enough time to prepare. The Royal College examiners themselves recommend an absolute minimum of 3 months preparation to be able to successfully, pass the AKT. And 3 months is intensive. Like, you could do it in 3 months, but it will be tough. And so if you've got a particularly busy rotation or you've got a busy life outside of work, I've got 3 young kids, okay, then 4, 5, even 6 months might be better to allow you more time to go over things, especially some things you might need to go over more than once if it's something you're less confident or less familiar with. Focus your revision to maximize your marks. So stats and admin, only 10% each, but if you prepare for these effectively, I've seen lots of doctors get 90% plus in stats and admin. Getting 90% in clinical is very, very challenging, okay? But see, if you can get 80% in stats and admin, 70 is enough in clinical, okay? And going through the examiner's feedback report to pick up on which are the weak and key areas they're likely to retest can be useful. Ultimately, whether you pass AKT or not is about clinical, because 80% of the exam. You don't do well in clinical, you could have 100% in stats and admin, you will fail the AKT, because 160 of the questions are clinical. One of the things that you want to do as a reference, it's worth downloading the Rcgp curriculum. However, you can see it's a huge document. It's 268 pages plus. So it's as a reference. Also, it's not like a checklist. It's not easy to just pick out the topics. There's a lot of reading to do that, but it's useful to have as a reference. If you just want to have an easy checklist, we've actually published one because so many people have said that they would find that helpful. It's actually in the format of a checklist. We've taken 580 or so of the key topics from the curriculum, and it's split into clinical, and those sub-split by the different curriculum headings mapped to the curriculum. And so as you're reading, just tick them off, okay? Then there's a separate section for stats and for admin. Other things that you might find as part of your learning, so to use as part of your reference or your reading alongside questions. So the Oxford Handbook of General Practice is a good reference text. 5th edition is the current one. The 4th edition is so old, almost everything is out of date. Even the 5th edition is 2020. So a few things have changed since then. BNF, spending maybe a day on the BNF is quite useful. Read the beginning, principles of prescribing, pain management, cancer pain, and then maybe sort of the introductory section at the beginning of each chapter, which covers a sort of summary of drug classes. And then if you want to cover lots of guidelines efficiently, then you might have seen our clinical case card. So, we update these regularly, a couple of times a year. They get updated, so they're up to date as of current guidelines. It's 112 topic reviews, and they're mapped to the same things your questions are mapped to. So we have a printed version. Okay, we have a digital version, and there's a bundle where you get the printed and the digital. Okay, you can find details here. All right, and then the mainstay of your preparation alongside your reading is going to be practicing questions. So the eMedica AKT online bank has got over 2,200 questions now. It also includes a 200 question AKT mock exam. It's mapped to the same curriculum headings that the Rcgp use in the new curriculum. So there's clinical section mapped to the same headings. There's a section for admin, section for stats. There's a full mock exam. There's 4 mini mock exams as part of this, okay? And you all, if you're associates in training, can access Rcgp Self-Test. I'd recommend you all use that as your second bank. And then other useful banks, some people find past medicine helpful, some people find on examination helpful. Now, we've got lots of free support. So if you're not a member of the GP training support, someone will post a link. Do join that. We publish the 30 days before every AKT. I post one video every day with a question, an explanation, and some tips. There's also recordings on our YouTube channel of free monthly GP training that we ran during lockdown. There's several hours worth of CPD, about 16 hours worth. And we also run a free high-yield revision webinar, similar to this, but we just do questions and teaching. We don't need to introduce the exam because it's for those that are closer to the exam. Again, we post details of that in the group when we set a date for it. So someone will post a link for that. And then our AKT preparation courses, resources that we have all the way ranging from our most comprehensive program, which is our AKT Pass Guarantee program, which is 2 full-day courses, a half-day stats course, half-day admin, 10 webinars in total, over 225 hours, over 3,600 questions, 4 full mocks, a sort of day-by-day, daily tasks and weekly tasks, structured guided learning. And we collect data on your weak areas. So the last part of the program, each person gets an individual learning program to make sure they address their weaknesses. Okay, that's why we have limited spaces. Every single one's been fully booked since we started running it about 3 years ago. So that's our most comprehensive. It includes everything we do for AKT. Then we have AKT Pass Plus bundle, which is about 130 hours. Our full day AKT preparation course, which this is the one that we have run with Health Education East of England and KSS. Our AKT 200 question crammer course. So a full day where we go through 200 questions, but we did a 7 question mock, we'll do a 50 question mock. Go through the answers and teaching, repeat that 4 times. So we do 200 questions and cover 200 topics in one day. And then you get another full mock afterwards. We ran this one as a national revision course via the Rcgp website during the pandemic. And then our AKT masterclass webinar. So we have a half day for stats, a half day for admin. A lot of people like to attend both. They're on the same day. And then we have high yield clinical, where we cover the clinical topics examiners mentioned in the last sort of 10 years worth of examiners reports. But because clinical is so big, that's split over 2 evenings. So 3.5 hours, 3.5 hours, 7 hours in total. Okay, so these bundles, because they include lots of things together, they're hugely discounted, right? Now, we've been helping people pass AKT, not just people who are preparing for the first time, but lots of doctors who are resitting. And we're known for this and having expertise in this. And we have run courses on behalf of, as I said, Health Education East of England, KSS. We've run individual sessions for different training schemes in London, West Midlands, okay, and offered support now to thousands of doctors preparing for AKT. So that's a reminder of that. I'm going to talk about now the habits of the high scorers. What are the 7 keys to AKT success? A lot of them are really the opposite of the reasons why people fail. So number 1, plan ahead. Don't just sit the exam because other people are sitting the exam. Plan ahead and think, okay, when will I have good exposure to GP? When will I have, a rota that's going to be decent in terms of preparing? So for example, if you're in GP, that's ideal both for learning and for actual being able to study because you've got regular hours. Or if you're in a rota that's relatively quieter, some of you, you've got integrated training programs where half of the week is GP, half of it is in hospital, but you're not doing as many intense on calls. Whereas if you're doing something like A&E, it's not impossible, but you're adding an extra level of challenge because you're going to have a lot of nights, you're going to have long shifts, you're going to have lots of weekends. So it makes it more difficult for you to fit in study time because you're also going to be really tired. So plan ahead. When is a good time for you when you'll be able to dedicate at least 3 months? And if you're busy, 4, 5, 6 months to be able to actually prepare. Okay. cover the whole curriculum systematically. That's one of the things that people like about our AKT Pass Guarantee program, that our most structured program. It runs over either 90 days or 150 days, so either a 5-month program or a 3-month program. The learning's the same in both. The difference is the 150-day program, the first 4 months, we send you work every other day that you've got to get done within the next 48 hours, and there's some weekly tasks on top of that. The 90-day program will send you work every day, but we tell you exactly what you're to do. So you don't need to spend any time worrying about how am I going to cover the curriculum or what do I need to plan. All you need to do is do the work we send you. We've already planned it for you. It's detailed, it's structured. We'll cover all the key topics in the curriculum. And then we also will analyze your data and give you an individual learning plan. Number 3, understand the exam. Now, this is a good start, but if you want to understand that more fully, when we've got more time, our full-day AKT preparation course will give you a really good understanding of the whole exam. We've got more time to go into the depths of it. Number 4, master stats and admin. So a lot of people, if they're learning through reading and question banks and maybe a study group of friends, but they come to our stats and admin to just master that. And we've helped lots of people who this was their worst subjects turn it into their best subject and the area they ended up getting the best marks in. We've had lots of people get 90, 95, even 100 in stats and admin. Learn the subject, not the question. Don't just repeat the same questions 4 or 5 times and you've learned the question off by heart. Now you think you're really good at it, but it's that picture, it's B. You're just learning the pattern. You just remember the question. You're going to get a different question in the exam. So you want to learn the subject. So if you finish a question bank, you're going to gain more by moving on to a different question bank than repeating the same one 4 or 5 times. And actually read up on subjects that you get wrong so you understand the why of it. Revise all the high yield topics. So you want to cover everything once, but then what things do you want to go over a second time? Stats, admin, and all the high yield topics. And number 7, work on exam technique. Those that do really well, not only have they got great knowledge, they manage their time well, both in preparing and on the day of the exam. So they finish and have a few minutes left to go over and they're unsure on. They're confident in their knowledge, so they don't change good answers for bad ones. They don't overthink things. They don't look for conspiracies. They read the question carefully. They pick out the key words. And we have a big focus on exam technique at our full day AKT course. Okay, so look, to summarize, the AKT is all about applying knowledge, not just recalling simple facts, but applying it in a way that's relevant to UK general practice. So there's a case attached, there's a lot of reading. The organizational area is the weakest for registrars, but if you cover the material, you can turn it into your best. Similarly, evidence and stats, even if you don't like it, if you learn the key topics, you can pick up some easy marks. Ultimately, the bulk of your time should be spent on clinical. That's the most important domain and will determine success. The examiner's feedback and our checklist can be valuable to guide your revision so that you cover this curriculum systematically. And ultimately, if you allow enough time, put in the effort, do it the right way, prepare, and you will succeed. It's important to go in with a positive mindset. And I leave you with this from Lao Tzu, that a journey of 1,000 miles begins with a single step. And hopefully, after today, you're a lot more confident in, what to expect, why people might struggle. And so now you can avoid that, the habits of the high scorers. You've got a better understanding. Hopefully that will help you get a clear plan and just make that start early. And then each day do something. And, come the result, I get an email, I've smashed my AKT. Okay. So thank you so much. Have a great evening. I might see you at one of our courses or programs in due course when it's time for you to prepare for your exam.